This is the team that took care of the patient while the patient was in the hospital, among a lot of other people in the OR and in the hospital. Dr. Barsukova?
Good morning, everyone. Okay, this was a 41-year-old man who, man. This actually was female, my bad. She initially presented for evaluation of metabolic bone disease, and she presented initially with non-traumatic of multiple recurrent fractures of her foot. Beside that, she has a couple of other symptoms, which was she gained, some weight over the year. She also has a secondary amenorrhea for last 10 years. She did have some hair loss. She has symptoms of hirsutism on her chin. On exam, she also noticed, she has some lanuga hair on her face. And also she has an easy bruising, facial plethora, and also depression and significant fatigue. She has a history of hypothyroidism. She has a metabolic syndrome with the hyperglycemia. Also, she has hyperlipidemia. As I mentioned before, she had depression and anxiety, obstructive sleep apnea. She was on CPAP, and she has a history of the kidney stone, which led, with the sepsis. On her physical exam, she did have some mild acanthosis of her neck. She did have frontal hair loss and some thinning of her hairs. She did have positive dorsocervical and supraclavicular fat pads, and her face was cushingoid on the exam. She also, her body habitus was like she has a centripetal adiposity with the thin extremities, and her BMI was 35, almost 35. When she initially present, because I think Dr. Sampson saw her, she initially present to the Dr. Abadi, who's a bone specialist. They did a screening on her. We see her morning cortisol was within reference range, but her salivary midnight salivary cortisol was, both of them was elevated, was in 200s, which is within normal range, is less than, like 100. That's indicate what she has. Her circadian rhythm is basically abnormal here. And her rest of the endocrine workup, her 17-hydroxyprogesterone was normal, DHEAS was as well, and as well as the rest. We did see a mildly elevated FSH, but as we mentioned before, she has a secondary amenorrhea, and she has a normal testosterone level, basically. Okay, when she proceeded with the testing, we did a 1 milligram dexamethasone suppression test, which she obviously failed. As we see, her cortisol didn't suppress at all. Her cortisol was 29, while SATH was 86, which will, with appropriate level of dexamethasone, basically that indicates us what most likely it's SATH dependent Cushing disease. She also has a 24 urine cortisol, which shows which has significant elevation of the cortisol in her urine. I think that's just, we was making sure repeating her labs, which did show that her SATH wasn't suppressed and her free cortisol was within normal range. Okay, I think that's. Then she proceed with the imaging, whereas on the imaging she did found with the cellular cystic cellular mass. If we can see, I'm not sure if somebody can point it on the imaging, but you guys.
Yeah. Hi, this is Dr. Gupta. If you want to scroll on that, Tito, yeah, you can see it a lot better here. Yeah, as you have pointed out on the coronal contrast enhanced T1, you can also see it here. It's a kind of a lobulated mass on the right side in the gland.
Yeah, that's me just painting. JPO made it here. So, yeah, sorry, Dr. Gupta, go ahead. Yeah,
No,
and
no,
the
no, please,
gland is
please, no, please add what you have to. Please go ahead.
no, I was just going to highlight here that the gland is pushed on the left side and this stalk up here. So if you scroll on the T2 coronal, you just follow the other way around. Yeah, you can just follow the stalk, and you see that this tissue here was the normal gland, and you can follow this stalk. Scroll, 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 go the other way around, the other way around. Yeah, and you can follow this stalk here. So, and then all of this was the tumor, all of this area here, as Dr. Gupta was pointing.
Thank you. All right. So due to the imaging and the clinical characteristics, it was decided to take the patient to the operating room for a resection through an endoscopic transnasal approach. So I'm going to show the video. JP, do you want to comment on it, or do you want me to?
No, I can comment on it. Just one point, right? Just for the sake of a discussion, being a teaching series, and so as it was pointed out properly, like we have a combination then of clinical findings compatible with Cushing's syndrome, with hormonal laboratorial findings compatible with Cushing's, and we have the imaging compatible with a pituitary adenoma. When we combine the 3 points, it makes easy to go ahead and proceed with surgery. Of course, sometimes, and Dr. Stenson can comment further on that, the picture of Cushing's syndrome and disease is not that clear. Like we have overlaps with other conditions that makes the diagnosis not that, let's say, straightforward. And that's why all that blood work is really essential for all of us. So although you have an image, remember that the blood work and the hormonal assessment comes first for Cushing's. So that's extremely important and necessary. And I appreciate Dr. Sensor and teamwork here with us. In this case, when you look at the MRI scan, we would have to, the first thing is locate the relationship between the tumor and the pituitary gland that we just described in the MRI, and if there was invasion or not of the cavernous sinus. And with Cushing's tumors, I'm more likely with acromegaly tumors, they tend to kind of go laterally, and we have to be careful with the calf sinus. But here you're going to see that we didn't have to go into the sinus, but we did have to work nearby it. So let's take a look at the video. So the first part was the nasal approach. I think this case started to be recorded a bit more in the late phases. I don't know if we have Olomu here with us.
Yep, I'm here. So,
Oh, okay.
So we just finished the sphenoidotomy, and I'm using the keratins to extend the sphenoidotomies laterally. Then in the midline, remove the remnants of the rumor posteriorly. Now I'm using a sonopet to drill down the intersinus septations, which then allows us to expose the sella completely in the midline. And then we're now opening the sella here.
Yeah, perfect. Thanks, Olomu. So you see that we completed the opening of the sella. So stop there, please. So we open the cell, and then we, like in a case like this where there is no invasion, we go from the 4 blue corners. So the tissue is kind of like in the middle here, and then you have blue corner 1, superior intercavernous sinus on the right, cavernous sinus on the left, and then we got the bottom that we don't see really a lot here, but there is the inferior intercavernous sinus, and then our working space will be between those 4 areas. So go ahead. You see here, we're opening the dura with a sickle knife, and then after that, we use a round knife to dissect the plane between the dura and the tumor in the pituitary gland. And we try to carefully preserve that plane. This is until proven otherwise on Cushing's disease. So in this type of case, we favor to try to proceed with extracapsular resection. And you see, this is, I'm trying just to find the plane with the pituitary gland, which was here. So this tissue here is the normal pituitary gland compressed by the tumor, and now working on the other side, mobilizing the tumor away from the wall of the calf sinus. So here, just putting a pledge to separate that space, and then trying to work extracapsular now. And once again, the round knife separating that tumor from the pituitary gland. You see the gland much better now here. So this is the normal gland that has been preserved. And just mobilizing slowly, try to mobilize it from away from the pituitary gland. And this is already like, you know, the tumor here peeled a bit away. It's okay, we had already found the margins of the tumor. And then just working on this plane between tumor and gland. And it's really like a pull and push maneuver. And then you see here this adhesion to the gland we just transected with the scissors. And we had a small CSF leak opening. You see the CSF flowing here. Usual packing with flow seal. And you see the entire gland was pushed to the left side as we predicted based on the imaging as well. And just inspecting around. And at this point, we work mostly with curettes or dissectors rather than by suction technique, just to avoid any injury to the posterior pituitary gland at that posterior corner. Then we put some Surgicel, some fibrin glue in order to attempt to repair that area. And then biodesign, which is an artificial graft tissue. And that was followed by a mucosal graft. And glue. That's the mucosal graft now. Olo, if you want to put some comments there, I'm gonna feel free, please. Oh, you're muted.
So the question was always how to reconstruct if there is a very small leak. Then typically would use the dura is reconstructed and we use a free mucosal graft. For a larger size leak, we would use a nasoseptal flap. That tends to be the algorithm.
Perfect, thank you. Okay, I think that was the end of the video. And let's see.
Dr. Gentoft?
Yes, I'm here. Sorry, took me a little bit to unmute.
Thank you.
As you can see here, we have a very monotonous population of tumor cells. They have very plump cytoplasm with quite a bit of granularity to them and have sort of this bluish sort of look, sort of somewhat granular sort of look. If we go to the next slide, these stain positive for the transcription factor T-PIT and are strongly positive for ACTH. So this is good for a corticotroph type adenoma.
Thank you, Dr. Gentoft. So here is the postoperative imaging. This is a coronal T1 post-contrast, and you can see, like before, you can see the pituitary gland on the left side right here, following the stalk, and then there is no evidence of any residual tumor on the other side.
Okay, basically here's the way they just discuss patient who has multiple symptoms and signs of the Cushing syndrome, which was confirmed, by laboratory testing. Basically, this is post-op day 1. We see what she has a significant drop on her SATH, which is like post-op, right? Post-op, her SATH was 33, when in the next day in the morning it was 5.7. Also, we see the drop in cortisol, which is like indicates what patient in remission, and that's later on. during, I think the day, first night, she did has evidence of DI, and she required 1 dose of DDVP the first night, but in the morning, that's improved. And so later on the follow-up, she didn't have any signs of DI. On the day 8, she was prescribed, basically, she was discharged on Decadron 1 milligram daily, and that was done because the patient with the Cushing syndrome, they have, after resection, they have they have adrenal insufficiency, and we just don't want to basically, in Decadron in Cushing syndrome has a longer half-life, and that's why the patient feels better on Decadron. But I think Dr. Simpson was planning to transition her to hydrocortisone later on the road. Basically, in her follow-up lab, so mild elevation of TSH, which is more indicated when she has a primary hypothyroidism, and on recheck, it's normalized. I think that's most important. And I think I would like to mention one thing. When I mentioned about her amenorrhea for 10 years, that's likely secondary to her suppression of gonadotropin in setting of hypercorticolism. And also it can be because of her weight gain secondary to Cushing syndrome. I think that's the most important thing I would like to mention.
Thank you. So yeah, as Dr. Barsukova said, the patient did have an increased urinary output on the first night and had received a dose of DDA-PB. She didn't have any other acute events overnight and was discharged home the first day after surgery. On postoperative day 11, the patient presented back to the ED with clear rhinorrhea and increasing headaches. The patient at that time was admitted for management due to a suspected CSF leak and was started on Diamox and antibiotics. They tested the CSF for beta transferrin, and it was positive. And then as the leak didn't spontaneously resolve by itself, the patient was taken to the operating room again to repair the leak surgically. And I do have the video of the repair. Dr. Olomu, if you want to comment on it, or if not, I think I can comment on it as well.
Yes, so we'd use a free mucosal graft, and most times that heals okay, and that takes care of things. But in this case, obviously it did not. And so we then had to go with a nasal septal flap. So here I'm just removing the prior biodesign that was used to identify the source of the leak. Most of it had healed, but there was a defect where it looked like some gel foam had, like right there in that right inferior corner, where the gel foam had dissolved and the dura had not yet covered up the space. So just repaired it with some 2 layers of biodesign there, epidural, one in epidural fashion, and then elevated a nasal septal flap. So that's what I'm doing there, and then rotated a flap in place to cover the sides, and that took care of the leak. So then just put a little test seal at the edges of the flap to seal things up, and then we pack it with gel foam to keep it in place while it's healing. And then support that with some nasopore here.
Thank you, Dr. Olomu. So that was the case. If anyone has any comments or questions, we'll be happy to discuss.
One question for JP, please.
Hello, Dr. Vargas.
Hello. Just one question. I think that most of the time we can do, as you did in this case, removal with capsule. But many times the tumors sometimes not that firm and the capsule is not perfectly rounded, or I don't know if it's a technical issue. you always can do removal of that kind of tumors like that, almost in block resection, not piece by piece. Trying to find the plane many times is not easy because the tumor just comes out and it's impossible to follow, and to try to first see where is the gland in the MRI. I think that for me, I don't recognize many times where is the gland. So what is the tip for find the gland on the MRI before? First question. And then on the technical issue, what is the tip for try to remove in block, or at least almost in block, not the suction as many times we do.
Yeah, a good question, and I'm gonna want to hear as well the opinion of Dr. Chai Chen as well, so we can all debate. Well, in my opinion, it's like a twofold. So first thing about the MRI scan, the thing that I always look at if it is a macroadenoma and it's pushing the gland, so difficult to recognize the gland itself, is to look at the pituitary stalk and to follow the pituitary stalk to one of the sides. And when using the combination of the T1 enhanced with the T2, that usually gives us the location. I mean, it's some nuances that I learned that I got with from Fred in Chile, that he would always kind of highlight that. So first, follow the stalk, and I mean this T2 really helps a lot because we can see the differentiation between the tissue of the tumor and then the tissue of the normal gland that was displayed on the left side here. So to me, if I can't differentiate based on the gland itself, I follow the stalk, and that usually allows me to follow the gland. The coronal helps a lot, but if you really don't have a lot, look at the sagittal as well. And with the sagittal, you can usually see the gland sprayed to one of the sides. I mean, just push to one of the sides. So that's what I usually end up doing in that regard. So especially for Cushing's, because I fully agree with you, Dr. Vargas, it's actually, I would say, less than 50% of the cases that you can get an extracapsular, but I think we should always try to push to get extracapsular on Cushing's especially. But that's difficult. It's not in every case. So the first maneuver that I find important is to try to differentiate between normal pituitary gland and the tumor itself. So once you have find that plane, even if the tumor is extremely soft, you're gonna be able to, once I mobilize that away from the gland, everything else I feel very comfortable working with by suction technique or with dissectors. I'm not gonna injure the gland by, once I have that plane. And the other aspect is to be really comfortable in getting all the way to the cavernous sinus and superior and inferior intercavernous sinus, because the lateral aspect is what's going to also block your extracapsular dissection. So to find that space, so medial wall of the cavernous sinus, normal pituitary gland, diaphragma above, and then the floor, the cella below, it's really important. And for Cushing's, I think that we all should be very aggressive because it's a very aggressive disease. So we must be surgically aggressive as well. So all that floor, the cella, I think if we need to remove to be able to mobilize the tumor from bottom up and really inspect that, we should do it. And if we must resect the medial wall of the cavernous sinus, I'm also in favor of doing it. Of course, it's a technique that, requires some technique, experience, and so on and so forth. Finally, one more important detail is instrumentation. So I think that to do the extracapsular, I only feel comfortable with those with 3 instruments. It's the round knife that you saw, a 3 millimeters 45-degree dull curette as we showed, and that hockey stick curette that I demonstrated. So it's not to curette, but to dissect around and keep that plane and avoid injury to that fragment. Kai, would you like to add as well about your experience and how you like to do that as well?
Oh yeah, thank you. Well, everything that JP says I support. So identifying where the gland is, like you said, T2 is very helpful, especially the lesion is cystic. Sorry, I'll try to walk through it. T2, the T2 where it's cystic. If the lesion is cystic, it's better. It's easier to identify where the gland is, and you follow the stalk towards the gland, and you know where the gland is typically on imaging. The coronal is the best imaging for me to differentiate that. Also, the contrast enhancing images, obviously the gland typically enhances on the normal contrast images. So you follow the infundibulum towards the gland. So you have an idea going into the surgery where the gland is. And like you said, it's very important to identify the gland early so that you can preserve it and you know how you can be, how aggressive you can be elsewhere. Extracapsular dissection, like you said, you showed a great video of you dissecting. So I don't really have much more to comment. It's just you try to preserve that plane as best as you can. Blunt instruments are the best to do that rather than sharp instruments. And typically where you're limited, just like you said, it's the cavernous walls. That's the area that's the hardest to maintain your extracapsular dissection.
Thanks. Okay.
Hi, this is Dr. Gupta. Just quick comment. If we know upfront if there is a macro adenoma, we do not always perform a dynamic exam. A dynamic exam is a sort of a snapshot of multiple time points while the contrast is coming in and washing out. But dynamic exam actually can be quite helpful in identifying pituitary gland if there is any doubt where the gland is, because gland enhances much sooner than the adenoma. So if there is any doubt about where the pituitary is, one can certainly perform a dynamic exam to more confidently identify where the gland is.
Thank you, Dr. Gupta. Appreciate for the comment.
Thank you.
Okay.
Nice. You use Doppler always? That's another question. Doppler?
Always available. Always available. In that case, I don't think we needed it, but always available. Yeah, to me, I have to say it's more important than the navigation. So if I were to choose between one of them, I would have the Doppler. Because the one thing with the exposure is kind of like, to me, I always look at two things, in each side. So it's the clinoid segment of the ICA and the optic canal on both sides. I think we need to have that. If I can't identify those landmarks, it means that there is something wrong. Either we need more exposure, either need to drill more deceptations, but I need to be comfortable in identifying that. So every time that I'm working, I keep that on my field so I know where the carotid is, so I feel more comfortable with that. It's just one of those things that we got from, from microsurgical techniques of keeping the vessels exposed and identifiables. That allows us to, I think, push and kind of like do this as more like almost like carotid surgery type of thing to dissect that more safely. Okay.
Thanks, everybody.
Thank you. For the next case, we have Rohin.
Yeah, thanks. Let me just share my screen.
So for those who haven't had a chance to meet Rohin Singh is a medical student from Mayo in Arizona that is here with us for the last 2 to 3 weeks and is finishing his time this week with us and has done an amazing work in the clinical setting in OR and today is finishing with his beautiful presentation. So thanks, Rohin. Appreciate it.
Thank you, JP. That's very kind.